what's up? Thank you for watching another video. My name is Kanisha. I'm a registered nurse that works in the ER. I've been an ER nurse for about 4 years now, and I've actually been traveling for the last year. I started a series about 2 years ago on a trauma patient who had a GSW to their chest and to their abdomen. So on the first video, we actually went over airway and breathing. We're going to continue on to C and D in the trauma assessment. So it's going to be circulation and disability. So when you have a trauma patient, it's very important that you go through the ABCs in order. Now, I know that I'm talking about these steps step by step, but that doesn't mean that they're not all happening at the same time, and you're not doing it all by yourself. It's simultaneously happening, but for the sake of making sure that we all do it correctly, there has to be an order. Now let's get into circulation. You want to be looking at the skin. How's the temperature of the skin? Is it cool? Is it clammy? Are they warm? You also want to look at their pulses. Are they bounding, faint? Their skin color within normal limit? What's their heart rhythm? Is there any external bleeding? This is the second time you're looking for external hemorrhaging, but you're also looking for internal hemorrhaging. You might see the doctor do a FAST exam. A FAST exam stands for focused assessment with sonography and trauma. It's just a fancy way of saying they're just testing for any sort of free fluid in the abdomen that requires the patient to immediately go to OR. Now that we've assessed our patient, there obviously is external bleeding because they have 2 gunshot wounds. What you're gonna do is you're gonna wanna stop the bleeding. Is the patient losing a lot of blood? This is something we talked about before. MTP, which is massive transfusion protocol. It's basically giving the patient blood and fluid as fast as you possibly can. The other thing is if they're cold and clammy, we may wanna start some fluids on them. Blood pressure is low. In this case, it's hypovolemic shock because they're losing a lot of blood, which means that they're losing a lot of volume. And what happens with that is gonna decrease the cardiac output. That is the end of circulation. So the next step on the list is D, and it stands for disability. And this is going to show you the alertness of your patient. Initially, when you first start your assessment, obviously you start with AVPU. Are they alert? Are they just responding to verbal cues? Are they just responding to pain? Or are they unresponsive? That's your initial across the room assessment. Now we're getting a little bit deeper, and we want to see, are their eyes wide open? They're looking at you when you're talking to them. Or are their eyes closed and they only open them whenever you're speaking to them? Or are they only opening them whenever you have to do some sort of painful stimuli? Or they're not opening their eyes at all? Are they able to answer questions appropriately? Are they a little confused? Do they have some weird mumbo jumbo that they're speaking that makes no sense? Are they just making gurgling sounds? Or are they making no sounds at all? And lastly, on the Glasgow Coma scale, you want to detect how they follow commands. When you ask them to do something, do they do it? Or do they just move to painful stimuli? Have any abnormal flexion, any abnormal extension, or are they just not moving at all? How you score a patient: 15 is normal. You start to go down from there. Next thing in disability is you want to look for pupil response, which we call PERLA, and that is testing for pupils are equal, round, reactive to light, and accommodation. The size of their pupils, are they pinpoint, dilated? For that type of patient, they're more likely to have dilated pupils. So that's the end of disability. Something that's very important to know, especially on a gunshot victim, you want to know if that bullet, if it went straight through or if it is dislodged in the patient. And how you can determine that immediately is by rolling your patient and seeing if they have a penetrating wound on both sides of their body, and that is at a higher risk for internal hemorrhage and external hemorrhage as well. After we expose them, you want to cover the patient up with warm blankets. Depending on their temperature, you may want to give them warm fluids, and then you want to go to F, which is getting a full set of vitals, getting family information, more than what we were able to get from EMS. And that's where the full head to toe assessment is. That's when you get family history, patient history, and try, at that point the patient is a little bit more stable because you've gone through your A, B, C, and D, and that is your primary assessment. By this time the patient will probably go to CT. Typically with the trauma patient, they're gonna scan everything. If they're stable and they were able to control the bleeding. If they were not able to control the bleeding, that patient is probably gonna go straight to OR. That is a gunshot wound trauma patient. Once the patient leaves the OR, you are done. You really don't know what happens moving forward. And sometimes, from my personal perspective, it could be a good thing because there's a lot of times where we save the patient, we stabilize them, and they go to OR. and sometimes they don't make it, and sometimes they go to ICU, and sometimes it's still an unfortunate ending for the patient and for the family. And I know that I leave work that day, we did everything that we could to save that patient. We were at least able to stabilize them long enough to be able to go to the next department of where they needed to get to. And so it's definitely hard, and it definitely weighs on you from time to time. That's why it's important to have debriefing. It's important to have everybody that was involved in that trauma to just sit down and say what we could have done differently, what we should have done differently, what was a good outcome, what we need to continue doing. And if the patient doesn't make it, I think it also is a good aspect of checking on your coworkers, because we tend to mask our feelings and emotions as far as losing patients. I think it's just important to express that. So that's it. That is a trauma activation from an ER nurse standpoint. A all the way to D, and then your secondary assessment, what to kind of expect and how to treat those type of patients. So thank you for watching this video. I really hope that you learned something from it, and stay tuned. I'm gonna have more content coming soon. Thanks, bye.